Very honored to be here. My lecture will be maybe a little bit out of the directly of the field because it will not be related directly to the sepsis, but our complications and, to be honest, misdiagnosis. So there will be two cases first, and then a little bit of the theoretical part. One case will be myocarditis, and the second one, cytokine release syndrome. If you start with the myocarditis case, these are both cases that happened after the immunotherapy, so the modern therapy of the cancer patients. First gentleman, 77 years old, not special previous history, but he presented in our emergency department with cough, weight loss, general weakness. Underlying diagnosis is right side malignant mesothelioma. Surgery was contraindicated, and he was started in the ipilimumab and nivolumab immunotherapy not too long ago. The thing to remember here is he had some other complications before he presented in our emergency department, but were of lower grades. 8 days following his last immunotherapy session, dyspnea, palpitations, severe general weakness, loss of appetite. Our emergency department, tachycardic, hypoxemia, tachypneic, and it was worse in the supine position. This was the initial ECG that was first interpreted as STEMI, as subacute myocardial infarction. White complexes, some elevations, white QRS, troponin was elevated, and liver enzymes were elevated, and lactate was elevated, but not so the CRP, procalcitonin, were normal here. That's why they are not written on the screen. The dual antiplatelet therapy was started, admission to cardiology, and they agreed with the diagnosis. Troponin still rising at the cardiology department. Echocardiography showed severely reduced left ventricular function, with the right ventricle being unremarkable and the valves being unremarkable. Tachycardia was persisting. He was being too unstable to cardioavert on the cardiology department. They made a plan to transfer to the ICU for the transesophageal echocardiography, because if you looked at the ECG, also atrial fibrillation was present, which was not known before, and then to cardioavert. On the admission to our department, he was in cardiogenic shock with cardiac index of 1.4 on TEE, no thrombus, and he was electrocardioverted, but unsuccessfully. Noradrenaline, dobutamine started, cardiac index improved temporarily, but on the continuation of the day, his condition was deteriorating, and the suspected diagnosis of myocarditis was established. The invasive diagnosis was performed, clear coronary arteries, and the diagnosis was confirmed. This is the urgent bedside ultrasound, and bolus of steroids was given to him. The condition again stabilized for a few hours, but on the day 3 hemodynamic decompensation, echocardiography showed dilation of both ventricles, right and left. He was started on amiodarone and antibiotics, hemodialysis with Terranova membrane because of the rhabdomyolysis, but intra-aortic pump was inserted, but nothing really helped. His condition was deteriorating by the hour, and on the 6th day, he died on our department. The decision against ECMO was made because of his underlying diagnosis. The next case will be cytokine release syndrome. This was in the let's say, span of a couple of months. We are not a specific department for the oncology. We are internal intensive medicine department. So we think that these cases are very frequent for that fact. This was a lady, 62, almost the same symptoms, but there was a fever. Underlying diagnosis is metastatic mucinous adenocarcinoma of the lungs. Again, surgery contraindicated, and she presented in our emergency department 14 days after the last, again, ipilimumab and nivolumab immunotherapy. Tachycardic, hypotensive, and some hypoxia. On the lung ultrasound, right lower side is the tumor, but she was high CRP, high procalcitonin, acute liver kidney injury, and she was diagnosed as the sepsis of unknown origin. Oxygen supplementation, a lot of IV fluids, if you will see below 3 liters. That was in a couple of hours. She was still very, hypotension was continuing, and she was started on the ceftriaxone and flucloxacillin parenterally and admitted to the pulmonology department. There, she received additional 3 liters of fluids with antipyretics, and the second day there was echocardiography with hyperdynamic circulation with still signs of hypovolemia, despite those 6 liters of parenteral fluids and everything that she drank besides. Microbiological cultures were taken. Her condition was deteriorating, especially with the mental status and hemodynamically, and she was transferred to the ICU with GCS of 13, systolic blood pressure of 65, tachycardic, very hypoxemic, and she was started on the high-flow nasal cannula and dual vasopressors, but still hypotensive. 200 of albumin, nothing changed. There were big pleural effusions, very high CRP and very high procalcitonin. And then the hematology fellow named Peter Fazarins was on call that day in our hospital on the other department, and he came to us with this acronym CRS, that he thinks that this patient does not have sepsis, but that she has CRS. And my first question was, fine, but what is this? And then he told me that this is cytokine release syndrome. And I must admit that I still said, maybe explain it a little bit more, because the words are there, but I didn't know what this was. So, despite me not knowing, and he educated me there, we gave her methylprednisolone bolus and started the renal replacement therapy with cytosorb. Why? At that time in our hospital, we didn't have the measurement of interleukin-6. That is the diagnostic marker for this condition. We sent it to Medical Center Ljubljana, and we had the result in a couple of hours, and it was over 100,000. The value for sepsis is around 5. So these are very, very high numbers, which confirm the diagnosis. We upped the dosage of methylprednisolone, and then we had to get tocilizumab. Tocilizumab is interleukin-6, anti-interleukin-6 medication, which, again, we didn't have in our hospital at that time. We were calling, actually, the police if they could bring it to us from Ljubljana. They couldn't help us, but actually then the private sector stepped in and we got the drug. And after that, I really don't like this lecture after this point, because when we got the tocilizumab, there is actually nothing else to say. Because if we I have to get here. If we see this graph, this is the noradrenaline line, and this is the start of tocilizumab, and then at the end, this was something like 20 minutes after the initiation, we could start lowering the vasopressors that were almost discontinued to the next morning. So this lady stabilized in a matter of an hour, and she was transferred after 4 days in our department to the reference center to continue her therapy, and she is still alive to this day. So myocarditis and cytokine release syndrome, two severe complications of modern immunotherapy. Immunotherapy, so ipilimumab and nivolumab, are two of the drugs very often used. These are monoclonal antibodies. The Nobel Prize was awarded not long ago. But the immune-related adverse events are, we think, a little bit underreported. So the myocarditis, with heart being immunoprivileged organ, cytokine release syndrome is the complete dysregulation of immune system with key mediator of interleukin-6. The risk factors for both are combination immunotherapy. In our cases, both were the same, ipilimumab and nivolumab, and there are for both 4 grades, with grade 4 being the highest and life-threatening for both cases. For grading, the diagnosis is clinical, not laboratory ultrasound or anything else. It is clinical-based presentation that is the diagnosis, and of course, with clinical presentation, anytime median onset is around 14 to 30 days for both. For the cytokine release syndrome, around 2 weeks, but it can also be late. Higher risk are immunocompromised patients, and as we see in our case, typical drugs are nivolumab and ipilimumab for both of those conditions. For the myocarditis, one of the strange things in our case was the left ventricular ejection fraction is usually preserved at the beginning for the myocarditis related to the immune system, but in our case it was very, very diminished. Diagnosis for the myocarditis, troponin, history labs, ECG, of course exclusion of the coronary disease, but then we have very strict or complicated MRI criteria, which are in many ways the diagnosis is not possible because the clinical course is too fulminant for the grade 4. Cytokine release syndrome is the diagnosis of exclusion. Treatment, very importantly, the myocarditis, very high doses of steroids for cytokine release syndrome. These are ipilimumab is the single main drug to give. These were both very interesting cases for us. The literature is very, very scarce. There is no blind studies or long-term studies for these adverse events because they are still very, very rare. So we managed to publish both of those cases in the immunotherapy journal. Quick takeaways. So these adverse events are rare, but they're potentially life-threatening. Early recognition is very important. In the case of myocarditis, if you remember, I said that gentleman had some previous immune-related events that were mild. He had some skin rash. That was the main thing. But the problem is that he was never screened for anything else. We make also this suggestion in our paper to maybe target those patients that have some mild adverse events in the history and expand the screening at, let's say, regular intervals. The diagnosis, clinical and laboratory, treatment must be immediate, high-dose corticosteroids, and tocilizumab in the case of CRS. Multidisciplinary approach and early detection. One other thing, maybe some of you will, now the bell goes off of the procalcitonin in the case of CRS. The thing is, when we looked at the studies for the cytokine release syndrome, procalcitonin was never reported in those studies. Also, they were focused on CRP and leukocytes, but the procalcitonin was not reported, and we think that those numbers are also elevated, but in the case of this, in the early days of studying, the studies might not be published if all the data was available, as the procalcitonin is still favored as a sepsis-specific biomarker, but maybe it is not so. Thank you very much. That is all the thing.